from University of Roehampton, speaking about the route to gender dysphoria.
Okay, the reason I came to explore gender dysphoria is because of my son being a trans man. So it alerted me to quite a lot of questions I hadn't really considered before, and sociology of diagnosis then was one of those. And I found a framework in Uttall and Nettleton's organizational papers in social science and medicine, especially, is usually quite useful to think also category, process and consequence. I'm at a very early stage of research, so not very little data. But I just conducted a focus group with 4 young trans persons, and I'm going to draw on some of this data to explore a few issues then. I'll make 3 observations. Firstly, I'm going to consider category then by looking at the medical classification of the relatively recently included diagnostic category of gender identity disorder, under which then gender dysphoria is located. I'm also going to consider some of the changes in approaches to transgender persons that have taken place over time. And I'm going to link the medical classification to the cultural dominance of a binary understanding of gender and how this impacts on transgender identities. And finally then I'm going to discuss the effect the classification system has on the process of diagnosis. Before moving on to the medical classification, I'm going to start with a couple of quotes from the focus group. So being diagnosed sounds like an illness. The wording in the doctor's letter is very medical. I couldn't look at it. They talk about you in a very medical sense. And the second one, the letter focuses a lot more on that you used to be female and not on now. They keep using your birth name all the time. It makes out that the person you are now is the problem. So from these quotes, we can see concerns then regarding the pathologizing connotations of diagnosis, as well as its effect on one's sense of self and one's identity. And we can see how both the category and consequence of the diagnosis is in evidence. So in the first quote, the respondent associates diagnosis with the confirmation of a disease, and so by feeling unwell. However, once allocated the diagnostic label, gender dysphoria, the respondents did report feeling quite good about themselves. So the opposite of well, really. They said things like they felt confirmed as the person they were. They felt relief after the diagnosis, that it was proof and it made it more real and people believed them, all that sort of thing. And the diagnosis then appeared confusing because on the one hand it was a welcome affirmation because it legitimized them, but at the same time it was a pathologized. So the consequence for your identity and sense of self is also evident in the second quote, where the reference to birth sex as the true sex became upsetting. From a medical perspective then, it's the birth sex that is the defining part of the patient. And by not being able to perform your birth sex and feeling uncomfortable with this, you are by default considered sick and then categorized using the diagnostic label. The naming of gender dysphoria then was something the participants had sought, but the way in which it had been delivered came then with added baggage and the consequences for their sense of self. So rather than simply being a route to well-being, it was a confirmation of a pathologized self. And these comments from the respondents share concerns raised by activists in the USA, reported by Burke, among others. And they've been advocating depathologization of gender identity disorder. And critics argue that distress, which is one of the sort of gender identity disorder diagnostic criteria, isn't the result of the gender identity itself, but the effect of living with social stigma and experiencing prejudice and discrimination. However, diagnosis is required before anybody can be granted access to transition-related treatments, so it's then necessary to explore the classification of this disorder. And there is agreement across a number of contemporary medical classification systems how to identify, define, and treat people who present with symptoms suggesting gender dysphoria. For example, the current World Health Organization International Classification of Disease 10, although ISD-11 is being developed at the moment. But this classification includes the heading Gender Identity Disorder in the section on mental and behavioral disorders, where transsexualism is differentiated from dual role transvestism and gender disorder of childhood. And a similar classification is found in the American Psychiatric Association classification, DSM-4, where gender identity disorder was first included in 1980. DSM-5 was published in the middle of last year, and I'm going to return to that later because there have been some changes, but I'm using these three because they kind of coincide. In the International Classification for Primary Care, the ICPC-2, so in other words, the classification that GPs draw on, transsexualism is found in the psychological category under sexual preference concern. Broadly, it's a mental illness with a focus on a disordered identity. However, this is a relatively recent agreement, and it's important to look at how different classifications have reached agreement. And the reason why ICD-10 and ICPC-2 share definition of transsexualism is due to the introduction of symptoms and listening to patients that took place in the 1970s. And Armstrong explains that while ICD was initially set up to record the cause of death, it introduced morbidity in 1948, but didn't include symptoms until 1975. So it wasn't until then the inclusion of symptoms that a match with primary care actually became possible. Because in primary care, reasons for consulting were recorded, and these didn't really then fit morbidity classifications, but they were congruent with symptoms. So these broader developments in disease classification systems have resulted in an agreement on the classification of gender identity disorder in a relatively recent addition to the classification system. And I want to go back then to the 19th century, when there was evidence in the medical literature of the existence of transsexuals. So it's not that this is a recent phenomenon or anything. And in the Lancet, for example, they were considered in 1895 to be impersonators. And in the first half of the 20th century, we saw sexologists and psychologists exploring transsexualism and refining definitions and seeking etiology and then in biology. And they developed the classical transsexual, and this was a definition that was based on personal characteristics pointing to presentations that contravened accepted gender norms. In 1973, Fisk, who was an endocrinologist, concluded that the term gender dysphoria would allow for the inclusion of a broader set of criteria, creating then a disease label rather than a profile of personal characteristics. He also argued that there was a need to consider elements of present-day living rather than just sort of catalogue of the patient's past. And so he argued that patients had to learn to present themselves in terms of, or they had learned to present themselves in terms of their childhood and so on, so their stories would actually fit that classical transsexual definition. And this was something they wanted to do away with. Harry Benjamin then, who was a medical pioneer and set up gender identity clinics already in the 1960s, where he provided hormone and surgical treatments. But again, seeking etiology in the neuroendocrinology. But his name has then lent, his name has been used in the standards of care for gender identity disorder. That was an association that's now called World Professional Association for Transgender Health, which was established in '79 with his approval in 1979. And so they developed these standards of care, and these standards of care remain as a guide in medical encounters with transsexuals. So instead of learning the definition of the classical transsexual, now you have to learn how to present yourself as competent in performing the opposite gender. So there's evidence then that listening to transgender people has taken place over a long period of time in medical encounters, but the interpretation of what they say has varied in line with the classification system. And Boker and Starr argue that classification systems provide a framework for organising the social world shaped by moral and political values, while simultaneously remaining fairly invisible. However, they suggest that this represents a co-construction of nature and society, rather than a projection of the social onto the natural. they argue that medical classification blurs the boundary between an either-or system and one that's based on negotiation. So the tension that could arise in classifying gender identity disorder is related to the bureaucratic nature of classification systems. And Boker and Starr work from the premise that to classify is human. Armstrong takes issue with this and suggests that classification itself is what makes us human. And Davey, in her study Recognizing Transsexuals, Personal, Political and Medical Legal Embodiment, argues that universal essentialist understandings of binary distinctions between male and female are at the root of constructing and defining transsexual experiences. So following Boker and Starr's premise that nature and society are co-constructed, we also need to consider our cultural understanding of gender. Being either male or female is a deep-seated basic assumption in the Western world. Despite deconstruction, postmodernity and critiques of essentialism, it has a powerful hold on our understanding. While it could be argued that transsexualism could be seen as a challenge to the binary gender system, this becomes difficult because of the medical legal confirmation of a two-gender system. So both in law then and medicine is the two-gender system reinforced. One of the participants in the focus group found it difficult to conform to this binary gender category and preferred to refer to themselves using the third-person pronoun, so in other words, they instead of he or she. And Eskin and King discussed these kinds of responses among the many interviewees they had found and applied this analogy. And so they identify migrating stories then among people who moved from one gender to another permanently, so assimilating into the new gender or the chosen gender. And then there were oscillating stories where people move back and forth between the two-gender position, and here they use the metaphor of tourism, so you can become quite familiar with the language and culture of the other, if you like, but you nevertheless return home from time to time. And then we had negating stories where people seek to ungender themselves, and this can be seen as part of a process of migration. So in other words, you remove the trace of the birth gender before transforming into a chosen gender. In this sense, it becomes a liminal phase, but there are many who now seek this as the end process, and therefore presenting a challenge to the dual gender system. And these are particularly coming out then in transcending stories that go beyond and seek to subvert the binary gender system by being political and openly challenging. So any sense of passing as one or the other gender is forgotten. But medical diagnosis then seems to be dependent upon whether a patient in Eskin and King's terms seeks to migrate or not. Transcending appears to be the most problematic, and this was evident among my respondents, and the respondent who preferred to think of themselves in the third-person pronoun hadn't managed to secure a diagnosis and had the following response from the GP: "We don't do your kind here." Smith in Gender Outlaws argue that people get upset with transgender people who choose to inhabit a third gender space rather than pick a side. And as I mentioned, the DSM-5 has dropped now, has changed, and it's now dropped the gender identity disorder label and replaced it simply with gender dysphoria. So therefore they are signalling now, it's not the identity that is pathological, it is the distress over the disagreement between the birth gender and their identity, rather than simply experiencing this kind of demand. And this change hadn't impacted on the experience of my respondents, where you could see the effect of the ICD-10 and the ICD-2 classification system in the process of seeking diagnosis. Managing the encounter with doctors in order to access diagnosis relates on anticipating what's required, and this is something that people have talked about throughout the day. And so you develop strategies then to avoid any hindrances. And there was quite a lot of discussion in the focus group about accepted ways of presenting yourself in order to be diagnosed. And Davey suggests that people adhere to rehearsed narratives, and we can see a number of those. So for example, being trans enough is important. You have to act hyper-masculine. You can't be feminine if you're a trans guy. You're not allowed to be masculine if you're a trans woman. So affirming the binary gender order and performing your chosen gender adequately is then important. So this is reminiscent really of the classical transsexual personal characteristics that people learned in the past in order to access treatment. It was clear that these were areas that people discussed with each other, and in the focus group they were talking about that, and also obviously these were online discussions that took place as well, so there's a lot of information about how you need to present yourself. So self-diagnosis clearly takes place before even contemplating seeking out a diagnosis, because you have to be very informed. So diagnosis then is about distinguishing between genuine and false performances of gender, it appears. But as Boker and Starr point out, classifications are dynamic, and judging by the move in the DSM-5, there are changes taking place, and it would be interesting then to see whether ISD 11 will follow that lead. So just to conclude, the inclusion of gender identity disorder in medical classification renders a person's identity pathological. And this is further complicated because it is a mental illness, so-called, that is treated using body technology. So it's really quite confused in that sense. In addition, it's a diagnosis that serves to affirm a binary gender order. And the process of accessing the currently defined diagnosis illustrates the way that medicine as an institution can act as an arbiter of what is an adequate performance of femininity and masculinity. And the consequence for transgender people is a tension between accessing desired medical interventions and maintaining a sound sense of self. So we need to ask, really, to what extent access to treatment is a possibility without pathology. And I think that, again, is a sort of question that has been raised throughout the day. So I'm just wondering if the classification moves in the direction of DSM-5 will then only allow those who are considered distressed to be able to access treatment. So you then have to learn to perform distress adequately. Then so people who just experience incongruity between the birth gender and their identity need to maybe resource them, decide body technologies